Rebecca is the project manager, National Safer Supply Community of Practice and Substance Use Health Network, London InterCommunity Health Centre. Thank you for being here tonight. Over to you.
Great to hear so many great discussions. Some of what I'm going to talk about overlaps a little bit with what some others have said, and I think that's fine. I think it's going to give us some things to talk about and some points for us to take home with us. I'm following Rebecca's lead by trying to give you a few key messages, key points to take away. Rob, you're very right. I could talk about safer supply for hours and hours and hours. But let's have a look at this. Basically, what I wanted to do is share a couple of key messages with you, because right now there's so much confusing information that we're seeing in the media. So I want to take an opportunity to clarify a couple of things, especially things that you'll want to think about when talking about developing a drug strategy. So 5 main points that I'd like to leave you with. And I'm going to start by sharing the 5 points with you, and then we'll dig into each of them a little bit more. So the first is that the problem is the unpredictable and toxic unregulated drug supply. Second, that the goal of safe supply or safer supply is to reduce harms related to the unregulated drug supply, or we also think about that as the illegal supply or street supply. Third is that we have evidence that is showing that safer supply is helping people. It's reducing deaths and also improving quality of life for people. Also, I want to make sure that we talk about the fact that we need all the options. There's not a competition between harm reduction and treatment and decriminalization. All of these things all go together. We need to have as many options for people as possible. And the 5th point that I want you to know is that there's evidence-based resources for you to get factual information. So there's some trustworthy sources of information that I'd like to direct you to. Okay, so let's start with the first point, the problem being the toxic unregulated drug supply. So the reason I want to talk about this is because when we're talking about a drug strategy, we need to identify what the problem is, right? So how you define a problem is what's going to inform what solutions that you look to and will consider. So defining the problem is a really important piece. And we sometimes hear that the current crisis is referred to as an addiction crisis. And Tara and Shalisa already talked a bit about this, about the importance of, sort of questioning that. And I too want to challenge that idea because although substance use disorders or addiction is a serious issue, and we need massive investments in resources and attention into substance use treatment. But substance use disorders are not the reason for this current crisis. Shalisa and Tara showed slides that showed about how over the past 10 years, we've seen deaths from substance use skyrocket, but rates of substance use disorder have not increased. They have not increased between 2012 and 2022, which we have the data for. This is not, substance use disorders are not causing these excess deaths. People who are dying from drug toxicity don't all have substance use disorders. Shalisa and Tara showed that 1 in 3 people who died did not have a substance use or disorder or addiction. They were people who used occasionally, recreationally, or maybe even just one time. So focusing on treating substance use disorder is not going to solve the death rates that we're seeing. We've also read a lot about fentanyl, and the impression is that fentanyl is extremely dangerous. Actually, like other pharmaceutical drugs, fentanyl, though very powerful, can be used safely. And in fact, pharmaceutical fentanyl is used every single day in healthcare settings, even with children. So the difference between the fentanyl that's used in hospitals and the fentanyl that people are using in the streets is that one is regulated and one is not. So a drug that's regulated is produced in sterile conditions. We know the contents of that drug, and we know how strong it is. We know how much can be used to produce the effect that we're looking for, and how much will actually cause harm and be dangerous. But there's no way to know the contents or potency of fentanyl from the street supply. There's no regulation of illegal drugs, so there's no way to know how much to take or what effect it will have, whether it will help you or hurt you. There's no way to know whether what's in the drug you're getting or if it's even what you think it is. And this is what makes illegal drugs dangerous, the fact that it's unpredictable, unregulated, and toxic. And this is why people are dying. They don't know what they're taking or how much they're taking. So it's the unpredictable and toxic, unregulated drug supply that's the problem. And so that's what the problem that we need to develop solutions for. And one solution that can address this is the supply, and finding a way to make the supply safer for people. And that's where safe supply comes in. So safe supply. So the goal of safe supply is harm reduction, not addictions treatment. And that's really important to note. So the safe supply works to reduce harms from the unregulated drug supply. The point is that you take a drug of known quantity and quality, you know the potency, you know the contents of it. It's a pharmaceutical drug, a regulated drug, so it's safer for you to take. That doesn't mean that there aren't risks. It means it's a safer drug to take. There are many different models of providing safer supply, but right now it's only offered through a medical model because of the legal or the legislative and regulatory context that we're in. So we need other models. Right now, we just have this medical model, and that really restricts who has access and really focuses on people with substance use disorder. So it does not address those occasional recreational users. Currently, there are about 24 funded safer supply programs in Canada, predominantly in BC and Ontario. And those 24 programs provide care to about 2,000 people, but there's probably upwards of 6,000 people on safer supply, 6,000 to 7,000 people on safer supply across Canada. So to give you an example of how the program works, I've made up a person named Allison, totally a person in my imagination. But let me tell you about this person. So Allison's been using opioids for more than 10 years. In the past year, she's had 4 overdoses, and she's terrified that she will die, and she does not want to die. She's tried methadone and Suboxone and says neither have worked for her in the past. She was diagnosed with Hep C a few years ago, but never followed through with treatment because her housing was so unstable. She was moving around all over the place. Right now, she's been living in an encampment, and while living in this encampment, that's where she met an outreach team. And when she had her last overdose, she was referred to the Safer Supply program at her community health center. So to get into the Safer Supply program, she went through eligibility screening, where she met with an outreach worker, a nurse, and then a doctor to do all the intake assessments. And once they decided that she was a good candidate for Safer Supply, they started her on the medications. And every day, Allison goes to the pharmacy to pick up her medications. She takes a long-acting opioid as a witness dose in front of the pharmacist. So the pharmacist watches her take the long-acting drug. And then they give her her day's supply of a short-acting drug that she can take as she needs during the day. She's found that since starting Safer Supply, she's much better able to manage her substance use. She rarely needs to use any drugs from the unregulated market. She's had no overdoses. She finds that she sleeps better and has had more time during the day to do things because she's not caught up in trying to figure out where she's going to find drugs in order to prevent withdrawal. So with this extra time she has during the day, she's been able to do things like meet with her health team. She's started on Hep C treatment. She's filled out applications for housing, and she started counseling. She started volunteering at the health center, putting harm reduction kits together, and she's hoping to take a course to become a peer worker. But best of all, she started reconnecting with her family. Safe supply has not just been about a prescription for people like Allison. It's also been about access to primary care, access to wraparound supports like system navigators and counselors, access to basic needs like food and income, and access to social supports. By addressing the risks of the unpredictable, toxic, unregulated drug supply, Allison was able to stabilize her drug use and connect with all of these services. And we've heard from people like Allison that they got their life back, even though they're still using drugs. They're now using them safely and able to plan. So the third key point is that safer supply is saving lives and improving quality of life. So Allison is not alone. We have safe supply is a new approach that's been embraced, and there's a lot of research underway. And over the past year in particular, we've had a ton of research produced. And Shalisa was the lead author on a fantastic review of the evidence. And I'll refer you to that evidence review at the end of my little chat here. So some of the evidence that's coming in is showing that people are having a lot of improvements in their life, that it is reducing death from all causes, actually. And overall, we're seeing that safe supply is a very important tool in the toolbox. So it's an additional tool that we can use to support people who use drugs. So much of the research so far has looked at individual outcomes of people who are on safer supply, as well as how they use the health system. And we are seeing benefits to the health system, reduce healthcare costs and such. But there's still a lot of research that's underway. And this also includes looking at looking at impacts on communities, including if there are unintended consequences happening. So the fourth point I want to leave you with is that we do need all these options. So safe supply is part of a continuum of care, and it can provide an entry point to social services, healthcare, and even addictions treatment, if that's what people are looking for. Like I say, it's just another tool in the toolbox. The key is that we need to provide lots of options for people who didn't previously have many options. Safe supply is now a possibility for people who found that, methadone didn't work for them. They were one of the people, methadone just didn't work for them. Suboxone just doesn't work for them. But safer supply is helping stabilize their lives and preventing death. We also need non-medical models of safe supply. There's been there was one pilot of a community model that had very promising results, but for those models, we need some regulatory changes. We need decriminalization. We need expansion and harm reduction services. We need treatment. And I'm really glad we had Rebecca here to talk about the importance of prevention, particularly for youth. We need to figure out how to meet people where they're at and open as many doors as possible for them. And really importantly, and Rebecca, you also talked about this, the importance of addressing like the social and structural determinants of health. We need to look at poverty. We need to look at housing, food insecurity. We need to look at stigmatization, all of these things, because they all impact people's relationship to substance use and involvement in services. And really importantly, we need accurate information, evidence-based information to inform our policies. Which brings me to my last slide for you. I've just got here, I started putting together some QR codes for you, and it got to be a very messy slide. So I'm leading you to the National Safer Supply Community Practice website. We have a fantastic resource library there. We also have an evidence brief, evaluation reports. We have a fantastic webinar archive, safe supply protocols and more. So you go there, you'll find anything. You'll also find a way to contact me. And if you are looking for some research, some evidence-based information, please reach out. My job is to help share that information with you. So please do reach out. And so just the final takeaways again, the problems of unregulated drug supply. The goal of safer supply is harm reduction. Safe supply is working, it's saving lives. And I've got here, safe supply is not contributing to deaths or increasing substance use diagnoses. But the point I wanted to emphasize here is actually that we need all these options. The more options, the better. And there's evidence-based resources.
Okay, thank you, Rebecca. So, Rebecca, first off, I just wanted to ask, would Allison would she have a substance use disorder? Is that?
Yeah, so currently, because of resource constraints and the capacity of programs being really small, people, and also because of it being within a medical context, there needs to be eligibility criteria. And in a medical context, they're working with people who do have a substance use disorder, or what some people might think of as addiction.
Right.
So yeah.
Because my question, well, my thought was, how are we getting to those people who are like the one-time infrequent users?
That's it.
So how are we reaching that? But let me just ask you this. I think you need to address this question because we're hearing it on the political stage now, that people with safe supply are selling a safe supply to buy the unregulated drugs. Can you provide a response to that?
So this is a very big discussion, and
Yes.
There's lots of people on this call who are really well informed to speak to it. I'll say very quickly that right now we're lacking evidence around exactly how big of a problem that is in terms of coming from safer supply. Diversion definitely occurs. What we know through previous research is that people do share medications. And often it's within their immediate circles, as opposed to, getting it out to the wider public. Programs are really small. So like I say, there's probably about 6,000 people in Canada. We've got research from BC that shows, and Paxton, I'm going to make sure have you double check me here. There's about 4,000 people on safer supply out of about 180,000 people with a substance use disorder, more or less. Yeah. And we can talk about the difficulties of like diagnosing the substance use disorder and all of that. Yeah. So we need to really be like, there are protocols and policies in safer supply programs to try to address the drivers of diversion, so the reasons why people divert. And there's policies and consequences if people are discovered to be diverting. But diversion is an issue that we need to be watching, learning about, and figuring out how to address.
Right.
Others on the call want to chime in there? I think this is a really important point.
Well, I think just to jump on that, I see that someone from the Toronto Health or Harm Reduction Alliance pointed out that if people were selling their safe supply, the data would not show such a significant reduction in overdose mortality and all-cause mortality. So I think we'll leave it at that. So thank you very much, Rebecca, for your presentation on this very timely, this topic that certainly has been in the news quite a bit.